And there we have had 20 years ago very many trials comparing zoledronic acid with placebo, denosumab with placebo. And the consensus today is that if patients have high risk to relapse, early breast cancer, that we do advise adjuvant bisphosphonates or adjuvant denosumab. In my country, these drugs are not reimbursed because they don't have the FDA label, but we have these drugs. So we are driven by patients who are been given anti-hormone treatment, where we know that the bone might become more fragile. So we do a DEXA scan, and if the patients are osteopenic or osteoporotic, we can give these drugs. We have oral bisphosphonates, alendronate. We have zoledronic acid, 4 milligram, 5 milligram, which is reimbursed yearly if there is osteoporosis. So we have cheaper drugs that we give the patients at high risk. There is absolutely also a place for denosumab, and in other countries, but not in my country, this drug is used based on the studies that have been done. I refer to the study published in the New England Journal of Medicine, where denosumab was given every 6 months on a regular basis in high-risk patients, and this clearly met the initial primary endpoint that was favorable, but we, in my country, we rather give bisphosphonates. Also, if you give this lower dose less frequently, there is less ONG, but we can come back on that later. So here I have copied for you this clinical guideline, how to deal with patients and having metastatic bone lesions, the first line of treatment, second line of treatment, and progression. And this is something that has been published in Nature Reviews Disease Primers by Professor Coleman from Sheffield. And part of my presentation, I have asked him to present some of his slides, and that is one of his slides. So you can look into it, and what you see is, depending on the symptoms, depending on the number of bone lesions, and we also in Leuven de-escalate the monthly zoledronic acid to the 3 monthly if patients achieve disease control on systemic treatment. So that's the schedule that we do use in the hospital. So this is the first part of my short presentation. The second part is on some recent disclosures from ESMO meetings. And this one is from an Italian group where they have compared long-term treatment with either denosumab or zoledronic acid, real-world retrospective observational data, where the endpoint was time to skeletal-related events, pain, based on the use of oral morphine, expressed as OME, based on the WHO pain scale. And what they did is they assessed the occurrence of skeletal-related events, the use of bone radiotherapy, bone surgery, comparing patients who were either on zoledronic acid or denosumab, and they concluded a comparable effect on the appearance of the first skeletal-related event, and also on the need for local treatment. This was similar. What was different was that patients on denosumab were 89% less likely to increase 1 step on the WHO pain ladder, that there was a reduction on the average of the numerical rating scale for pain intensity using denosumab, and also the time to reach the oral morphine equivalent based on the model need for morphine was improved with denosumab over zoledronic acid. And you can see these curves here. On the left, you can see this scale for the pain frequency and intensity. And on the right, you can see the dose of morphine equivalent comparing in red zoledronic acid with denosumab. So there seems to be a difference, but also not a difference that was reporting to time to radiotherapy. But this is clearly that these drugs have been compared with each other, and I thought this was a nice disclosure from ESMO. Another disclosure is from Leicester University Hospital, where they looked to patients with early and patients with metastatic breast cancer that were using either zoledronic acid or denosumab, but patients were able to switch from one to the other. And you can see the number of the patients that they included in this retrospective study, 455 patients. The majority were stage 4, and they looked into osteonecrosis of the jaw that was likely related to any of these two medications. So patients could not have a history of radiotherapy to the jaws. They needed to have one or the other drug. And then you can see in figure 2 that the medication-related osteonecrosis of the jaw was only appearing in 3.7% of the patients treated in this hospital between 2015 and 2020, based on these retrospective data. And the majority of these patients that they had with this ONG had risk factors, and these risk factors, as you all know, was a dental intervention. They also looked to the place where this ONG was reported, and this was most likely in the mandibula more than in the maxilla. And also concurrent use, none of these patients were using bevacizumab, which is a risk factor. None of these patients were used corticosteroids, which is also a risk factor, but you can see that some of these patients who did develop ONG were concurrently on CDK4/6 inhibition, anti-hormone treatment. But dental intervention clearly is a risk factor. And you can also see other potential risk factors like diabetes, hypocalcemia, and current smoking. So this is rare, but we have to be aware of this potential side effect. The third of the 4 disclosures is this one from Italy, from the Gemelli Hospital in Rome, where these colleagues, in a very small cohort of important patients, so perimenopausal patients with high-risk early breast cancer, and the median age was 45, 88.4% were under age 50, also retrospectively collected between September 2018 and January 2025, all receiving adjuvant endocrine treatment and bone protection with denosumab, given to protect the bone, looking into all these potential risk factors, BMI, tumor stage, vitamin D levels, smoking or not smoking, comorbidities, and that they here report the results that denosumab, concurrently given with endocrine treatment, is very efficient in preventing osteoporosis, reducing bone turnover, and improving the bone density with an excellent adherence. And so this is what they do in Italy and also in other centers. They do give denosumab for prevention. And we would also advise it absolutely if the patient has osteoporosis. Otherwise, we give the drugs that are less expensive, like oral alendronate on a weekly basis. The last disclosure that I believe was interesting to mention is that denosumab is being considered in a study to prevent breast cancer, and the study is called BRCA.P, So it's a prevention trial. Christian Singer from Austria is the principal investigator to prevent breast cancer by inhibiting rank L signaling. And based on this trial, I was looking for experiences in the world. How can denosumab delay or control disease if you have bone metastatic breast cancer? So what they did is they looked into thousands of patients with ER positive, HER2 negative breast cancer treated with CDK4/6 inhibition. They selected the patients, 1,399, with bone metastatic disease, treated with CDK4/6 inhibition, so quite recently treated patients, and they traced retrospectively 46 patients with a germline BRCA1 or BRCA2 mutation. Of course, these are very small groups, but they were looking with the Kaplan-Meier curve if patients who were on or patients who were not on denosumab had an effect on the response on treatment. And what they did conclude was that patients who had the mutation treated with denosumab had a longer real-world PFS compared with patients who didn't have denosumab. So this was quite impressive, and the study does suggest that denosumab administration in the BRCA1/2 mutated ER-positive HER2-negative breast cancer with CDK4/6 and endocrine treatment has an improvement in the real-world median PFS if you treat this patient with denosumab as a bone agent, as compared to the group with no denosumab. This has not been published, but this was presented recently during ESMO Breast. So to conclude, we now have one clinical case that we recently had in UZ Leuven. This was a young patient, because I do believe that the patients in China are much more likely to have breast cancer at an earlier age than we have in Belgium. So this was a perimenopausal 40 years young patient with a PT2N1, primary surgery, white excision with sentinel lymph node procedure, and this was clinical node negative, but it turned out to be pathological node positive with one positive lymph node and high-grade lesion, MammaPrint. So the gene expression profile was high risk, and she had ovarian function suppression with chemo. And then we continued on ovarian function suppression and letrozole. She had, at the start, a DEXA scan with a lab checkup that we always do to check the bone metabolism. And this patient was not frail, but very often we give vitamin D and calcium supplementation. And we decided to give this patient who did not have osteoporosis, neither osteopenia. We did start her on prevention, and we did give her the choice, because her renal function was normal, between zoledronic acid once every 6 months, like in Zofast, or to give weekly oral alendronate. And my guess is that based on the Austrian breast cancer study group, denosumab is a good alternative for this patient. So to conclude, bone-targeted treatments significantly reduce skeletal-related events in patients with bone mets and should be part of the standard treatment. They should be continued throughout the course of the disease. There are good data, head-to-head comparison, that denosumab for some endpoints is more efficacious for the prevention of skeletal-related events and fracture prevention based on these trials. Low frequency administration of any of these drugs, what we use with zoledronic acid, is de-escalating after 1 year to the 3 monthly application instead of the monthly. that might need evaluation in good prognosis patients. There was recently a disclosure in the New England Journal of Medicine that it might be useful, but this is just to treat osteoporosis every 18 months instead of every 6 months. So maybe we are overdosing these patients. Bone protection reduces metastasis to the bone. It improves survival, and it prevents osteoporosis and fragility fractures. And we do bisphosphonate. We do give bisphosphonate as an adjuvant treatment in postmenopausal patients with a high risk. And if we do give denosumab, we always give, if we stop denosumab, 1 infusion of zoledronic acid, because otherwise we see this rebound effect.